we have 3 presentations left. And we'll have discussion after, I think, presentation both after scleral fixated IOL and Yamana's case, so that both the secondary IOLs we can discuss together. Yes, Dr. Aleksandra.
Excellent. So thank you so much for the organizers for allowing ASRS to participate, and thank you for everybody on this panel. I've learned a lot from each one of you each time I hear you present. So I'm going to talk about scleral sutured IOLs, and we also prepared a couple cases of both scleral sutured IOLs and Yamani technique to kind of foster the discussion. And I call it 8 ways to avoid complications. These are my disclosures, which are not pertinent to this presentation. And I think pearl number 1, you really need to know what's inside that eye, because a lot of time as retina specialists, we're taking things out that we didn't put in. And in this case, we discovered that this patient actually had a superior tunnel. And as we are performing the surgery, we have to think, okay, if there's a tunnel, that's probably a PMMA lens. We weren't able to get records for this patient. And we wanted to avoid that tunnel, but yet we needed to make sure we put our sclerotomies for the vitrectomy. And we ended up doing a temporal tunnel as opposed to superior tunnel, which is my usual approach. Also, you have to be aware if there is sometimes the remaining cortex is very, very hard and difficult to remove even with vitrectomy and acts like intraocular foreign body. And Dr. Chi would be comfortable with that, of course. And the other thing is, if you have a capsular tension ring, you have to be very aware of that. This is my usual technique. If it's acrylic lens, I bring it up with soft tip, and then I use my forceps, and using Kugelin hook, I feel like very atraumatically you're able to bring it into the anterior chamber, and then you can make a small corneal incision at this point, self-sealing corneal incision, and remove it after you cut this lens. So knowing what's inside, I think, is extremely important as you plan your surgery. And then you have to decide what you're going to put inside. And, obviously, if there's something to rescue that's inside, you can rescue that. But these are our options when it comes to scleral fixated IOLs. We have CZ70BD that has been around for a very long time. It's a PMMA lens. It's quite large. And I think it has fallen mostly out of favor because of the big incision that you need to make to get the lens into the eye. So we have AO60 or Acreos and MX60 or Envista, which were not designed for scleral fixation, but we as retina specialists have been utilizing them pretty extensively, using the Gore-Tex sutures most commonly to secure them to the sclera. And AO60 does allow for 4-point fixation, and MX60 allows as well kind of 4-point fixation if you use it in a hammock approach. So I think it's very important to measure twice and cut once when it comes to the surgeries. I usually mark before I create my peritomies, before I put any trocars in, so I know that I'm centered. And there's a lot of discussion how far back and how far apart you go. And I've modified over years and started going a little bit more further back, and I go 5 in between. And I think it allows for a nice location of the lens. This is a kind of a warning tale not to pull too hard on the sutures as you put the lens into the eye. This is Envista, which is probably more prone to this than Acreos. And you can see as the fellow is putting the implant in, I was the one pulling on the Gore-Tex, and we can see how the Gore-Tex just cut that eyelet. And we had to remove this lens and to place another lens into the eye. And we've published, along with several colleagues across US, on these eyelet fractures. And a report was a total of 25 scleral sutured Envista MX60 lenses that were displaced secondary to eyelet fractures, and 5 were sustained in the were noticed during the surgery, which was one of ours, but 20 were noticed post-operatively. And the question becomes, was there something intraoperatively then one could notice that might have led to post-operative fracture of the eyelid? So something to be aware in this particular lenses. And another tip, number 4, is to leave ends long till the end. So this is how we tie it 3-1-1. And then before I cut, I do rotate them just a little bit to get them ready in the position as I'm going to bury them. And the reason I found this useful, I operate a lot with the fellows, and it was a great fellow, but sometimes when you're watching somebody else do it, it's very hard to judge what the tension is on that lens. And so as we rotated, I realized that the suture was quite loose. And this was the one time I had to untie the Gore-Tex. And it's much easier. You can untie it and retie it, but it's much easier to do, obviously, if you have longer ends still remaining. So I leave the ends long, and then just move it to make sure I like the position of the lens. Everything looks good. And then I cut the suture. There's been a lot of debate whether PI is necessary, and there's been several reports of pupillary block with different types of lenses. I find that doing a small peripheral inferior PI is not problematic for the patients. I don't make large PIs. I don't make them at 9 or 3 o'clock to avoid glare, and I haven't had any patient complain, but I personally do put a PI, and I'd be curious if anybody on the panel does as well. And hypotony is an important consideration in these cases, because I don't suture these lenses. I do these cases 25 gauge, so it's pretty small sclerotomy, but at the same time, you can have some oozing at the end of the case. So I tend to rotate the knot. You wanted to rotate the knot in general to avoid any delayed exposure of the knot and conjunctival issues. And then as I rotate the knot into the wound that was the trocar wound, then we pull back a little bit, and it essentially kind of closes it from the inside. I think also very important to prevent hypotony is to make sure that when you create your initial peritomy, you're aware of both conjunctiva and tenons. I think as retina specialists, we don't have a lot of respect sometimes for conjunctiva. And I've learned doing some of the PDS cases and to respect the conjunctiva and tenons a little bit more. And I'm very aware where my tenons and where my conj are. And when I close the peritomy, I make sure that I close the tenons over that suture, and I think it prevents long-term health of the eye and prevents erosion. And of course, if you're using AO60, there has been multiple reports of opacification on air or gas usage. It's interesting because it doesn't happen every time. And I think if you have an eye that's complex and you might think that they might need air or gas down the road, you might want to pause and think which lens you're going to use as your secondary IOL. And I presented a case actually yesterday in more detail, but it's important to remember that the sutures that we place are still foreign bodies. This is a gentleman who had intraocular foreign body trauma. We removed the cataract, removed the foreign body, did vitrectomy. Several months later, we implanted the secondary IOL. He had this area of pigmentation that was initially thought to be like a speck of dust. The patient is a mechanic. It was cultured in the office with negative culture. And then during the surgery, because he kept getting conjunctival erosion, we noticed these skip lesions. And upon culture, this patient actually grew curvularia, which is black mold. And this patient is a fascinating case because the patient was a year out from his initial surgery. He was 20/20 with that secondary lens and no evidence of any endophthalmitis or any cell at all in the eye. But he did have this curvularia growing on the Gore-Tex suture. So in summary, I think points to keep in mind when you operate, whether you use scleral IOLs, some of these apply obviously for any secondary IOL. Do know what's inside, because you need to really plan your wounds. You need to plan how you're going to get things out. If it's a PMMA lens and you can't cut it, you need a larger wound. Also knowing if you have capsular tension ring, and sometimes that capsular tension ring might be sutured. It's great to get op reports, but which it's not always possible if it was done a long time ago or at another hospital. Measure twice, cut once. That applies to any surgery we do. Do not pull too hard, and especially with AO6, with Invista lenses. Sorry, you need. There's been reports of that eyelid fracturing, leaving ends long till the end. So if you need to readjust, you can create the PI. Rotate the knot to prevent hypotony and conjunctival erosion. Avoid aero gas in aqueous lenses. And remember that these are the patients you're going to follow for a long time. We've been doing a lot of scleral fixated IOLs, I feel like, in the last 10 years, but we don't have a super long follow-up on this patient. So we have to see how these patients are doing 30 years out. And I really appreciate everybody's time. And I will stop sharing my screen so we can, I think, have a couple more cases.